Welcome, and thank you for taking the time today to review a prototype that I've created to demonstrate a rapid cycle point-of-service methodology for implementing electronic health records. In order for you to fully participate in this interactive demonstration, I want you to imagine that you are a nurse in a busy emergency department that will be transitioning to a new EHR in 6 months. It's my job to find the best way to train you to use the new health information technology at the bedside so that you're comfortable with it in a real environment after go-live. At the same time, I aim to ensure that system functionality complements your clinical processes, either by working within your existing workflows well, or by offering an opportunity to enhance your existing workflows for them to work better with the system. Let's get started. The methodology is comprised of 4 distinct steps. The general idea is that after an initial introduction where I highlight some rules of the system and review the goals of training, we'll head to the clinical area to test the system in a real environment. Don't worry, you'll be shadow documenting while your colleagues provide patient care and they continue to document in the current system. This exercise is twofold. First, I want you to get a sense of what it's like to use the technology in a real patient environment, but without the pressure of actually taking care of patients. And secondly, I need you to assess it critically so that you can provide feedback about your experience with the system so that we can make sure that we ultimately have the best product before we go live. After the session, we'll discuss what worked well and what didn't. And finally, those lessons learned will be shared with administration and the EHR developers so that we can make changes as appropriate. I'm going to walk you through each of these steps so that you get a better sense of how the process works. First, we'll head to the classroom. Now that we're in the classroom, I'm going to provide you with some general rules of the system. This is going to help you while you're using the real system in the live environment. Because remember, this is not going to be a class where I actually walk you through the process. I'm going to give you these guidelines, and then we're going to put you in the real environment, and you're going to be on your own to try to navigate through the system. This is largely because we want to test whether or not the system is easy to navigate and intuitive. But you need to know some ground rules. So the first really important ground rule is that to document on any patient, you're going to first have to see them as having been registered and arrived into the system. The only people who can do that are registrars. That is an institutional decision. So when you first log in, you'll see a list of patients who have been registered, and to get into their record to do the triage, which is what we're going to focus on today, you will double-click on them. Close at the bottom of all patient screens will actually advance you to the next section. You can also jump between sections by using the side navigation. This should be obvious when you look into the system, but if it's not, I can point it out to you once we get into the clinical area. And third, the system will only allow you to move beyond triage once an ESI has been entered. So acuity is going to be kind of the next step to move into other sections of the chart. This is going to be important, as the rapid assessment, which is what we're going to be focusing today, is just one portion of triage. And so you can do as much of the triage as you want before moving into the next section, but you absolutely have to enter the ESI before you can move into the next section. So as I mentioned, triage is actually a pretty long process. Rapid assessment is the first step to move people along in the pipeline, and then, as you know, our clinical workflow is to do a bedside triage. So there are 5 components that have to be completed per our department regulations to be considered a complete rapid assessment. The first is obviously chief complaint. Next is a triage note. This can be brief, 1 to 2 sentences. The next would be a quick set of vitals. You would then add any RN interventions. This is only in the case that those actually exist. And finally, acuity. As I mentioned before, ESI must be entered before you can move on to the next section. Before we head in and start practicing the system, let's just go over the general goals of this session. So first, and primarily, the intent of this is to establish whether or not there are inconsistencies between the system functionality and our department workflows as they currently exist. And this can go in one of 2 directions. Either the system could hinder our current department workflows, which we think are the right way to proceed, or we may see some opportunity based on system functionality to alter our workflows to make them better. I want feedback on both of those. The next and obvious goal is to assess whether or not the system is easy to navigate. Is it intuitive? Are the steps that are sequential in our process, are they laid out sequentially in the system? We want to test the ergonomics. So this is going to be less appropriate today in terms of triage, but when we get to a point where we're printing labels or we're administering medications and we need to use a barcode scanner, we need to make sure that we have all of the resources at our fingertips that we need in order to complete a task. And finally, we're open to any other feedback that you want to provide to us. Any lesson that we can learn is going to be a really important lesson in informing the design of our final system. Okay, so this is the point where we would normally head to the clinical area so that we could shadow document. Unfortunately, because of the limitations of this prototype, we're going to actually do all of that here, where I play the patient and you play the nurse. So at this point, we would be in triage, and we would be standing back out of the way as unobtrusive as possible, but close enough so that we could listen to the conversation that was happening between the rapid assessment nurse and the patient, and that we could document the patient's answers to the rapid assessment nurse question in our system.
Can you please verify your name and age for me?
Yes, my name is Jess Training, and I'm 26 years old.
Okay, and what brings you in today?
Well, it's kind of a long story. I was doing some yard work yesterday because it's such a nice day out. And then my boyfriend, we've been together for 6 months. He's just the best. He came over. He surprised me with lunch. I don't normally eat chili, but he was so sweet to bring it, so I ate 2 helpings. Then I went back outside to plant some more flowers. I didn't really think anything of it. I guess it was around 7, I don't know, maybe 5 p.m. I started noticing some really bad heartburn. I took 5 Tums. Is that okay that I took so many? My mom always says that I take too much stuff. Anyway, I wasn't really paying attention to it because I also had a headache, so I decided to lay down, but I took a bunch of Advil. When I woke up this morning, my chest still hurt. I don't know if it's acid. Maybe I was having a heart attack, but I didn't notice because I took too much Advil. I kind of do that sometimes. I don't know. Who knows? Anyway, I'm here now, so I guess you can say that I'm having chest pain.
Let me just type that in. Okay, let me get a set of vitals from you. Your temp is normal at 98.2. Heart rate is normal at 75. Your blood pressure is good at 130/80. Are you in any pain now? And what is your height?
No pain. I'm 6.
Alright, I'm going to order an EKG since you're having chest pain. You can go ahead and sit right there and someone will come and get you for your EKG soon. Let me know if you need anything.
Sit right there? Okay, thank you.
She's an ESI 3.
So at this point, we probably would have observed several triage rapid assessments and entered them so that we get an idea for the flow. But this is just an interactive demonstration, so we'll just do one. The next phase is phase 3. We would head back to the classroom or some other meeting area where we can openly discuss the lessons that we learned from our experience and talk about what the improvements are. Okay, so I'm going to give you some Post-its and ask that you make a note of the things that you liked about the exercise on the yellow pads and make a list of the things that you think need to be improved on the pink. All right, let's take a look at your first yellow Post-it. It says Hard Stop ESI. Can you explain what that means?
Yes, I like that there's a specific step that marks the end of the rapid assessment. I like that the system won't let me move on without it, since acuity is really an important step of the triage.
Perfect. Okay. The next Post-it says Saves before advancing.
Yeah, I like that I don't have to hit save every time I enter something. I was kind of worried about the extra step of saving everything or moving on and forgetting and having to do rework.
That makes sense. The last yellow note says List of Common CC.
I like that I had the option to search for chief complaint, but think it'll be extra helpful to have the list of common ones always present. It will help expedite the triage for sure.
That makes sense. All right, let's look at some of the things that you identified as opportunities for improvement. The first pink note says, comment from chief complaint doesn't carry over to note. Can you explain why that's a problem?
In the paper records, these two fields were really close together. Now I feel like I need to re-enter information that I already entered.
That's great feedback. The next note says, interventions coincide with chief complaint. Move up. Do you mean to move nursing interventions to an earlier portion of the process?
Yes, I always order an EKG immediately after hearing a chief complaint of chest pain. If someone came in with a chief complaint of flu, I'll immediately apply a mask. I think these two portions of the record should be closer to one another.
I agree. Let's see. The final note reads, permitted too much story. What does that mean?
I need to remember that this is only a rapid assessment. I let the patient go on and on. I could use a refresher on how to politely remind the patient to be brief.
I think that's a really excellent point and is actually a great segue into the next portion of this exercise. I've got two colors of dots, green for things that will require system or programming fixes, and purple for something that you think is more training or education related. Can you place the appropriate dot on each of your pink stickies? Yes, I agree with your selection. Well done. Do you have any questions about this portion of the process?
No, thank you.
Okay, so now that we've had our debrief, we've assessed what worked well and what didn't. We've separated them into categories. And in those categories, especially in the what didn't work well, we actually triaged between what didn't work well because of system functionality and what modifications need to be made by the EHR vendor versus what didn't work well because our own process was broken. The one thing that didn't work well, that didn't have anything to do with system functionality, was that the nurse let the patient go on and on before actually getting a chief complaint out of her. And this is probably an opportunity for some re-education about the purpose of rapid assessment and the consequences of people backing up if we don't move through it quickly. So that feedback is going to get sent back to the nurse educators who are going to address it separately. For now, we're going to focus on the two items that did come up that were related to system functionality that need to be modified by the programmers of the EHR. The first modification that the programmers are going to make is related to moving around the side navigation. So what we learned was that nursing interventions usually come at the same time as the chief complaint. So once she got the chief complaint of chest pain, the next thing to do would be to order an EKG. So on the side navigation, we're asking the programmers to move nursing intervention so that it follows chief complaint and so that that navigation happens in a more sequential fashion. So the second modification that we're going to ask the programmers to address is that the comment in the chief complaint section does not reappear in the notes section. And this is important for a couple of reasons. One, which you wouldn't have actually known based on today's training, is that the physicians actually only see the notes. They see the chief complaint, they see the notes section, but they don't see the comments associated with the chief complaint. So it's important that that information be included in the notes. Second, from a practice perspective, we like to have that information be redundant. In our old paper forms, it was right by each other. So we're going to ask the programmers to carry forward the comment from the chief complaint section, so since yesterday, into the notes section so that you don't have to retype it or copy and paste it. Now that we've sent off those modifications to be made to the EHR vendor, we need to wait for them to be done. But once they come back, we're going to repeat the process again to see how those modifications worked out, to make sure that they didn't break something else in the process of fixing it, and to just, in general, get more familiar with the system, with the functionality. We may find additional things that need to be addressed, or we may find that it actually works for us and that we're all comfortable with the rapid assessment component of triage. So, because they're relatively minor modifications, they should be back in about a week or so, so we will plan on repeating the process then. Thank you.